Nobody is so OCD, understanding and treating obsessive compulsive disorders. I am Carrie Steele with West Virginia State University. I'm the chair of the social work department there and also a member of the NASW board. I will be moderating, so just a couple of quick housekeeping things. If you've not already done so, please make sure that you enter your name into the chat. For attendance, if you're calling in on a phone, then please enter your name and phone number so that we can verify. There are closed captioning enabled. You can play around with the size of the text or turn this feature off. Please keep your phones muted. We would love for your cameras to be on. It's always easier to talk to faces, but we know there are internet issues in West Virginia, or some folks don't feel comfortable with their cameras on. But please make sure that we get your attendance. If you have questions, please put those into the chat. I will be monitoring those, keeping up with those, and asking those to Dr. Wilhelm or unmuting you at the end. So with that being said, I will turn it over to Dr. Laura Wilhelm, an associate professor with the WVU Department of Behavioral Medicine and Psychiatry.
Thank you very much, Carrie. So I just want to make sure before we get started, you can see the slides, and is my volume okay right now? Yeah, okay, I'm looking at you, Carrie. Yeah, thank you. So I am going to be talking about OCD today, or obsessive compulsive disorder. I hope this overview is useful to you. I think just in terms of practicalities, I am not the best at looking at chat questions, paying attention to what's going on. So I might suggest we go through the slides and then at the end, see how much time there is for questions. And I'll ask Carrie about that. And Carrie, if you feel like there is something going on where we really need to address it at the time, please jump in. And if you have to say it again, say it loudly so that I will hear and pause for a minute. Okay, so I'm going to move forward. The reason I mentioned the title, Nobody is So OCD, is because obsessive compulsive disorder is excruciating for people who meet the diagnostic criteria. We use the term OCD like an adjective in everyday life, and people who actually struggle with OCD really don't like that and feel pretty strongly about how it can minimize or trivialize suffering. Now, we say all sorts of things in society that we probably should rethink, but I want us to really consider how the disorder of obsessive compulsive disorder affects people's lives, what the cycle is, and not be so free in calling ourselves OCD or calling somebody else OCD. The International Obsessive Compulsive Foundation has actually done a pretty large campaign. OCD is not an adjective. So that's where the title came from. And again, I think anytime we understand something, we're so much more empowered to deal with it, whether it affects us, our family members, our friends, or just knowing about it for the greater good in our world today, which needs greater good. So my objectives today are to really go over what obsessions, compulsions, and the whole OCD cycle look like. There will be a pretty basic explanation of these fundamental concepts. So if this is review to you, I appreciate your being here. I appreciate everybody coming here this morning. We want to look at underlying themes of OCD so that you become more aware of how this problem manifests itself, because OCD can be really tricky and really insidious. And then we're going to talk about key treatment strategies, namely exposure with response prevention, or ERP, which has been shown to be the gold standard treatment for a psychosocial approach to obsessive compulsive disorder. So going over basics, when we say obsessions, you'll hear me talking about this a lot because I want you to leave with the idea that you can explain this to yourself and to other people. The obsessions are the thoughts that pop into my mind. They are intrusive, they are repetitive, I don't want them to be here. They can seem senseless, or they can seem like something that's relevant to my life, but they're like a brain hiccup. I did not ask for these intrusive thoughts. And that is key to understand. The obsessions are not anything the person is doing on purpose. Stomachs growl, we have hiccups, body organs do funny things. And our brain is an organ that can send out some noise. The obsessions are the intrusive, repetitive, unwanted thoughts. The compulsions are the behaviors, either overt behaviors or mental behaviors or avoidance that I do in response to the obsessive thoughts. We'll go over how this looks in some diagrams, but compulsions are how I respond to these involuntary thoughts. It's important to understand compulsions are 100% voluntary. I am deciding to do compulsions. Even if they become habitual and really automatic and they feel like they're out of my control, the compulsions are the part where we have some agency, where we can make some changes. And when we see the term OCD, the C, and I'll write this out for patients quite a bit, the C is not just a consequence of the obsessions. The C is our attempts to neutralize those obsessions, but the C is also the driver of the disorder, what keeps it going over time and really leads to people suffering. And then for it to be a disorder, we need to see the distress or the impairment. So people are suffering an hour or more a day with these problems, with intrusive thoughts and attempts to try to neutralize the thoughts. That's OCD. Now, OCD is pretty prevalent across the lifetime. 1% to 3% might meet criteria for this. We recognize that men and women tend to be equally affected, but the way OCD shows up at different points in people's lives can really vary. This is, in my opinion, and what the research shows, a chronic disorder. Sometimes people get really disheartened when we talk about that. No, we can't make it go away. We don't have that technology. We can help our patients cope with it more effectively. We do have those strategies. The age of onset usually is early adolescence to young adulthood. And then OCD, like many other problems, many anxiety disorders, is not going to come alone. It goes along with other problems. Certainly people struggle with depression. There are other ways to try to cope with the intrusive internal experiences that can lead to more problems. I think it is useful to consider some of the temporal relationships that get established in research. Much of the literature shows that when there's OCD and depression, the OCD often precedes the development of depression. And if my life becomes about trying to fight off intrusive, unwanted thoughts, life becomes very small. So patients engage in fewer rewarding activities. There's so much shame and so much embarrassment and so much misunderstanding. Life can get really small for people who are struggling with OCD without intervention. So those are some of the basics about the disorder. Now, these are some hallmarks I hope you will also consider when you think about OCD, because we don't want to just be thinking, this means the person checks too much, or this means the person is always washing their hands. Checking can be a form of checking OCD, or washing can be what I do in response to contamination OCD. And OCD can show up in so many other ways. So we have movies and TV shows. I mean, these are a little bit older, but there was a show called Monk. There was a movie, As Good as It Gets, with Jack Nicholson that's quite old at this point. But we see these demonstrations of characters engaging in repetitive behaviors. And in a way, that's helpful to make the disorder more known. We increase our awareness, but we also can limit or narrow our understanding of what it actually means. So another objective of today would be that you see OCD in the bigger picture beyond just how it might manifest in a really concentrated way. It's the doubting disease. It's a central feature of OCD. The doubt is there. And the thing is, we're all going to have doubts. If we're going to live fully, doubts are part of life. Doubts are part of decisions. There's no way to be sure. For our patients with obsessive compulsive disorder, they hate doubt. and they do anything they can think of to try to get rid of doubt. And there will be some statements that you hear probably over and over that you might be sick of by the end. This is the doubting disorder. And the main issue is people's demand for certainty. People are looking to be sure in a world where we can't be sure. And it's that quest, I've got to know, I've got to figure it out, that drives this problem. So I've mentioned brain hiccup. When we have the hiccups or when our stomachs growl, we don't like it, it's annoying, and we don't change our whole lives because of it generally. If I have OCD, my brain gives me an intrusive thought, and then in lay terms, I freak out about this thought, and we'll speak more about how that happens. OCD, I said, is chronic. It waxes and wanes over time. We can't really say why at this point in your life you're more likely to have OCD than this other point. Certainly biology plays a role. It's both a biological and a learned disorder. We often will see more problems for women struggling with obsessive compulsive disorder, either during pregnancy or after pregnancy. So there is this transaction between biology and what's going on in the environment. OCD, like every other disorder that we would think of from a mental health perspective, is a confluence of factors. Certainly the biology with the person's learning history, their stressors, their temperament, their medical and hormonal factors. I don't know if I already said that one, but a lot of things come together to create OCD. Why it's happening exactly at this point in your life, I don't know exactly. And we have ideas, but we don't know exactly what causes OCD. We do know that we have treatments that can be helpful. So OCD is stress sensitive. The stress can be good, like people who are getting married or taking a better job. It can be unpleasant stress as well. But what OCD does is it requires me to dread the thoughts or internal experiences that are showing up in my mind. You can't have OCD if you don't hate, dread, try to get rid of these intrusive thoughts. There's also sort of this idea with the patients who I see with OCD, and Jonathan Grayson has also talked about this. There's like this living in a fantasy world. If only it were this way, or if it could be that way. So people with OCD often have the ability to think and live by this idea, oh, it could be so much better, which kind of takes away from being in the now. It's like life is always being subtracted by how things should be. And never good enough is sort of a message that OCD infiltrates its sufferers with. Nothing is ever good enough. You're always going to have to do more. You're never going to feel safe enough. You're never going to feel clean enough. You're never going to feel moral enough. Do more, do more. And so when I'm talking about these features of the disorder, the more we understand OCD's tricks, this bully's games, the more options we have for managing. OCD can show up in so many different ways, and people have maybe seen multiple providers before they actually get an accurate diagnosis. The figures on this change. There used to be numbers like 7 to 9 years. I've seen up to 14 years can be an average people go without getting an accurate diagnosis or effective treatment. So we want to, again, be tuned in to how this might be showing up in our patients. Now, the thing is, OCD capitalizes on our ability to think, what if? What if? And that's really like our mind's way of saying, let's pretend. With OCD, the let's pretend is generally something horrible, catastrophic, unbearable in the sufferer's mind. But our patients with OCD have amazing strengths. We're people who are analytical, compassionate, creative. We want to normalize this with our patients. So when I'm having conversations with people about how this part of their brain shows up in ways that really bother them, this is the brain that's also made them incredibly compassionate in their caregiving job, or it's made them incredibly successful in their writing or in some of their music, or very conscientious at their job. So there are real strengths in the brain that also carries obsessive compulsive disorder. Nobody is their diagnosis. And again, that's where we get away from saying so OCD. You are so much more than this problem. And the more you understand this problem, the better equipped you are to maximize your quality of life. If we're going to look for themes, we're going to see people getting stuck. They're really slowed down. They're really hooked on ideas that show up in their mind. And like most anxiety disorders, the avoidance perpetuates the suffering. Now, in current DSM-5, OCD is in the chapter on obsessive compulsive and related disorders. So I say anxiety disorder a lot when I'm talking about OCD, even though it's now in a separate chapter of our diagnostic manual, because in my thinking and other people's thinking as well, it still fits more of how an anxiety disorder looks and how we treat it. In that obsessive compulsive and related disorders chapter in the DSM, we have our body-focused repetitive behaviors and hoarding. OCD is not hoarding, and OCD is not the same as skin picking or hair pulling. OCD has a lot of misery. People are trying to get rid of these thoughts and the suffering along with these thoughts, whereas some of those other disorders have more of a positive reinforcement feature along with the distress that shows up over time. So I think, again, recognizing what our brains do just universally is important. The figures on this vary, but we're going to say 80 to 95% of humans have intrusive thoughts. It can be, am I going to run my car into that guardrail? Am I going to hit that person while I'm driving? I'm in a work meeting. Oh, I just want to scream out this saying. Or I touch a kid in the hall. Did I touch their private parts? Do I want to touch their private parts? Intrusive thoughts show up. And we want to be clear, this is part of being human. In a classic study, when psychologists were asked to try to distinguish, are these the thoughts of people with OCD or are these the thoughts of people with normal controls? Yeah, I think I said that right. Are these the thoughts of controls? The psychologist could not tell the difference. We all have intrusive thoughts, and they can be bizarre and they can be senseless because our brain can think anything. Brains are infinite. They remember all sorts of things. They anticipate all sorts of things, but OCD is going to be a situation where my brain is very sticky for these unwanted thoughts. I have a thought, and for a variety of reasons, it hooks me. And instead of just letting it come and go, like, oh, that's a strange thought, I get freaked out. What does this mean? Why am I having this thought? Oh my gosh, if I'm having this thought about my baby, I shouldn't be around my baby anymore. Or if I'm having this thought about going to this meeting, then I shouldn't go to the meeting. So I treat the thought like it's really important, and then I change my life because of it. I think I've mentioned OCD is both biological. You need the physiological predisposition, and it's learned. And over time, maybe years, maybe decades, people have come to do certain behaviors to try to suppress the unwanted internal experiences. And they get more and more stuck, and life gets smaller and smaller. If we look across all types of obsessions, generally we're seeing about 4 themes: contamination, responsibility for harm, unacceptable or taboo thoughts. These can be like sexual thoughts or pedophilic OCD thoughts, thoughts that I think I'm not supposed to have. Blasphemous thoughts, that's a category under the unacceptable thoughts area. And then this idea that things have to be orderly and symmetrical, like everything has to be just right. Things have to line up perfectly. I have to, fix this way so it matches this side. But these are the general areas of how we might map the different obsessions that people present with. OCD, I will tell people from the beginning, is a disorder of attaching too much significance to your thoughts. So we'll write that out early on. Psychoeducation is a big part of treatment. OCD is a disorder of attaching too much significance to your thoughts. And then it's also all the things you do to try to neutralize those thoughts. Here is a list of subtypes. So certainly we know about contamination OCD. That's seen very largely in our world, in our media. Harm OCD is where I'm afraid that I could cause harm to someone, or I didn't prevent harm from happening, leaving the stove on, driving across the street without checking to see whether that bump I went over was a person or actual speed bump. Sexual orientation OCD used to be called homophobic OCD. This is where I'm doubting my sexual orientation. I'm really afraid of being something different than I think I am. And this is something where it's the doubt that is so hard for people to deal with. They think they have to know their sexual orientation perfectly, and it's awful if they're not. Well, we know this is on a continuum. And even as I say this, these are themes or types of OCD, but the content actually isn't that important. And I'll talk more about that as we go on. Relationship OCD is, do I love my partner? Do I really want to be with this person? If his nose looks like that, can I really spend the rest of my life with him? All these thoughts about whether I actually love this person or want to be with this person, or there can be a lot of jealousy ideas associated with this. Maybe I don't love this person. Maybe I really can't commit. And I'm looking for an answer in my mind. I'm not going to get a certain answer, but the more I rehash and ruminate, the more confused and stuck I feel. Pedophilic OCD is actually not uncommon. And when people are afraid that they could molest a child or they have molested a child, this is excruciating because it calls into question people's entire beliefs about themselves. Again, bullies attack wherever they can get people. OCD is like a bully in our head. Scrupulosity is where the OCD really hijacks religious ideas. I've got to know that I didn't offend God, or am I praying right? Or if I have that thought about that person, does that mean I'm going to go to hell? How do I be sure I never go to hell? I thought this when I was in church. Wonder what the pastor looks like naked. All these thoughts that I don't think I'm supposed to be having, I then resist them, fight against them, and they grow. And then I can get hooked on, am I blinking enough? Or how am I breathing? Should I be breathing like this? Or how do people blink? And so the sensory motor OCD can also play a role. OCD can take all sorts of formats. It's important that we help our patients see it's not the specific issue as much as bigger themes, like a demand for certainty. I've got to know for sure, which I don't get. A demand for perfection. It's got to feel just right. I've got to do this just right. And then there's a hyper responsibility component where I think it's on me to handle this. It's all my fault if this goes awry. So there is a lot of suffering involved in the different manifestations of OCD. Is there anything else I wanted to say about this? Oh, yeah. With assessment, I'm talking about this like we've established somebody has obsessive compulsive disorder, but on some of these areas, you might say, well, what if somebody really is struggling with their sexual identity? Or how do you know this person isn't a pedophile? You assess and you get the diagnosis of OCD, which is different from pedophilia, where people might like these thoughts. You do assessment that helps you figure out this is obsessive compulsive disorder. That's through the clinical interview, as well as assessment measures like the Y box, the Yale-Brown inventory, or the OCIR. I'm not spending a lot of time on those measures. We could talk about it more in chat if you want, but we've established this is not a person who really wants to molest children. This is not a person who really wants to run somebody down in their car. This is not a person who wants to hurt people in their health position. This is a person who abhors these ideas. They are terrified and repulsed by what their mind has given them. And so that really figures into how you appreciate what's going on. The thoughts are very ego dystonic. Oh my God, how can I be having this thought? Please make it go away. And that is the problem that drives the disorder. So how it might look is that I have this obsession. It may come just from my own mind. I have this thought and I get really nervous about it. It may be that I see something on television that reminds me of a mistake I might have made on my taxes 3 years ago. And then I start thinking, oh my gosh, are they going to come after me? So I have this thought and then I misappraise how threatening it is. This is disastrous. This is catastrophic. There is distress. We don't like distress. So we're going to try to make the distress go away. And that's where we do some type of ritualistic, compulsive, avoidant coping. And we're going to say, it's understandable that I want to try to make these thoughts stop. That's what we do in the external world. When there are problems, we try to make them stop. I'll often use the example of the printer here. If the printer started spewing toner everywhere, somebody would be telling me, unplug it or turn it off. If the water at home is flooding the kitchen floor, you turn off the water, turn off the faucet. We try to apply that strategy that works in the external world into our internal world, and it's not going to work there. The more I try to make it stop, the more the whole problem continues and grows, because I don't learn that those were thoughts that I could have let come and go. I'm so bothered by the thoughts that life becomes about trying to make them stop at the expense of quality living and at the expense of my values. So how does a thought become an obsession? I think this is interesting. I think Alec Pollard originally talked about this. It's just kind of helpful to consider. We have thousands of thoughts every day. Thoughts come and go. How might a thought become an obsession? Because the thought pops into my head and then I think, what does this mean? Or why did I think this? Or if I'm thinking it, it must be important. I can't stand thinking this. So it might be something about a person's health. It might be something about their partner. It might be something about their job. It might be something about their physical appearance. A thought pops in that seems hugely awful and intolerable. And because I think, why am I having this? It grows into something that becomes more intrusive and repetitive. So some of the beliefs that underlie these thoughts, certainly the intolerance of uncertainty. Are my hands clean enough? It's still COVID times, even though it's a lot better. Are my hands clean enough? Did I say goodbye before I hung up with that person? Did I really stop at that stop sign on the way back? Should I have answered that phone call? What if it was a telemarketer and they recorded me and now they're going to steal my identity? People with OCD can be very creative, but it's about, I can't stand not knowing. We overestimate threat and danger. There's this idea that I'm supposed to control my thoughts and be perfect. And the overimportance of thoughts certainly is a big deal. Not everybody shows that, but if I have a thought, for many people, I feel very responsible for treating it as if it matters. And this can, again, cause all sorts of problems. I've mentioned the hyper responsibility where I see everything on me. I forget that other people are involved in how they think and how they feel and how they respond. And then I have what might be called thought action fusion, where I think because I have a thought, the thought could actually come true. It could happen, what I'm thinking. So we'll do experiments like this. Just because I think that the refrigerator is open and milk is spilling all over the floor, does that mean it's happening? We might even call and leave a voicemail on the person's home. Your refrigerator is open and milk is pouring out of it. And then we have our patients go home and see. And that's really silly. But the idea is, just because I think it doesn't mean it's going to have consequences or effects on the world. And then also for many people with OCD, it may not be that they're afraid of a disaster that's about to occur. It may just be that they don't want to be anxious. And when they're anxious and in distress, they're thinking it's going to go on forever. How long is this going to last? I'm never going to be able to do my job if I keep feeling this way. I've got to make these thoughts go away, or I'm not going to be able to function. Okay. I'm not sure if a chat message just came through. Something popped up. So Carrie, I'm going to count on you to tell me if I need to do something different. Should I keep going?
Well, I don't know if you're going to talk about this later, but one of the questions that's come up twice now is, how do you tell the difference between OCD and anxiety?
It's a great question. And I think when we talk about anxiety, that's an experience of lots of different components. So for anybody saying they're anxious, I want to know, what does that mean to you? And so I'll ask, what do you tell yourself when you're anxious? What are you actually thinking? And they may say, I don't know, but generally they can come up with it. And if they're having a really hard time saying, I don't know what I'm thinking, then I might say, well, were you thinking life is great? And then they'll be like, well, no, I was thinking that I can't live this way anymore. So now I have a thought. So part of understanding anxiety is getting at the thoughts. I'll also want to know about what internal sensations people are experiencing. Is their heart racing? Is their chest tight? Is their stomach uneasy? Do they, just feel on edge? So there are those somatic or feeling internal sensation parts of anxiety. I'll want to know what people's urges are. Sometimes people will say they want to just pace, or they think and think and think, or they want to avoid everything. So there's an urge to do certain behaviors. And then I'll ask, what are the actual behaviors you're doing? And we'll map this out, because I don't know what somebody means when they say they're anxious. And then when I get more information about that and how problematic it is, it may be that we're normalizing anxiety as part of full living. And I say this a lot, I don't think I've said this here, but anxiety means we're alive. So even though our patients spend so much time trying to stop anxiety, trying to get away from anxiety, if we're going to be alive, we're going to feel anxious. If we're going to care, we're going to feel anxious. Anxiety tells me something matters. Now, if the anxiety is excessive and seeming to dominate my life, then that's a problem. We want to do something about that. We want to help them intervene in a way that aligns with their goals and values. But OCD versus anxiety, I hope I've made it sort of clear that anxiety is an experience we're all going to go through being alive. Let's find out what our particular patient means more when they say that. And then OCD certainly carries the experience of anxiety. I may feel very nervous, thinking something bad is going to happen. My heart is racing. I'm short of breath. I'm clenching my fists. I want to get out of here, but they're not equivalent. And I hope I answered that okay. At the end, if I just babbled and it wasn't useful, then maybe we could come back to it. Okay, examples of obsessions. I just presented some of the themes that overlie or underlie the obsessions. So I might have fears that I've contaminated myself or somebody else, that I've harmed someone. I left a knife somewhere and somebody could have gotten it. I, swiped somebody's car and I didn't even realize I was doing it. I rode over somebody. That's what that bump must have been. I think, oh my gosh, if I have this thought, maybe I will just punch my boss in a meeting at some point. In church, I might be thinking, I don't belong here. Do I even believe this? Do I even care about this pastor? The forbidden thoughts, like we said, pedophilic, OCD, just these unacceptable ideas pop into my head. And then needing things to be just so can be part of obsessions. Also, some people just think they have to confess, they have to tell anything they've deemed they've done wrong. And this shows up for actually a lot of my patients. They talk about how they're replaying what happened in grade school or what happened in college. And they're thinking, maybe they destroyed this person's life. Should I call them and should I apologize? And it was objectively not that harmful what they did, but now they're stuck in, oh no, I shouldn't have done that. Are they okay? I have to be sure. So that's obsessions. And then talking about how behavior becomes a compulsion. It's where I realize, okay, if I do this, I get some relief. I wash my hands. Okay, I feel better. Okay, now I've got to go wash them again. Okay, I feel better. And maybe I'm washing now for 5 or 6 minutes. And maybe my hands are cut and chapped and there are, places where they bleed. And I'm actually exposing myself to more contaminants in everyday life because I've washed so much. But I think, okay, that gave me a little bit of a respite. So that's what I'm going to do again. I do compulsions, or we call them safety behaviors, because it gave me some relief. The problem is the relief is temporary. It's not long-term. So I might call my sister to ask her about something I think I did wrong. Was this okay? I call her, I feel better immediately. I didn't really learn anything other than if I want to feel better, call my sister. It starts to become a ritual, reassurance seeking. Or, okay, I worried that what I said at that meeting really hurt that person's feelings. So then I confessed that I said this, and I confessed to this person that I said that. And they said, it's going to be okay, Laura, it's going to be okay. So that was reinforcing. But then I'm left on my own later. Is it really okay? So then I'm confessing again. And it may seem like I'm just trying to be conscientious or I'm just trying to be moral. That's not what I'm doing. I'm trying to be sure. The effort to be sure backfires in our patients with obsessive compulsive disorder. And then we have our learned behavior. I've done it so much, I don't even know how to stop now. It's just become part of my coping repertoire. And the thing to point out, which can be really tough for a lot of people, compulsions aren't just the behaviors where I'm confessing or seeking reassurance or ordering everything so it lines up just right. The compulsions can also be what I do in my head. So I might be trying to undo a thought. Okay, if I just say, I love God, I love God, I love God, I love God, that's going to make it be okay. Or if I try to reassure myself, I'm basically a good person. I would never do that. I'm a good person. I would never do that. Or I'm replaying, like thinking about every single step in the meeting. Okay, I did this, and then I did that, and then I did this. And it can feel like, okay, I'm just trying to understand and figure it out. I'm now in mental compulsion land. And the more I do that, the more OCD is going to take charge of my life. The compulsions drive the disorder, whether they're overt, whether they're avoidance, or whether they're the mental games I'm doing in my head. So compulsions, I hope I've made this case so far, but I do them because I want to prevent something bad from happening. And I do them because I want to know that something bad didn't already happen. And the demandingness of this really drives a person's behavior, because I feel like I can't function if I don't use these compulsions. How am I going to do the rest of my day if I don't go wash my hands again? Or how can I possibly continue with my work if I don't go back and check to see whether I really ran somebody over in my car or not? So in the moment, the OCD urge to do the compulsion feels so overwhelming. And I think I must listen to this bully. Well, if I listen, then I'm going to likely do a compulsion that gets me some relief. And then I'm going to need to keep doing the compulsion. And again, life shuts down. As I'm talking about this, the behaviors that go along with compulsions when they're overt, remember, we control what we do with our hands, our arms, our feet, our legs, our mouth. Those are behaviors. And I decide what I do with those parts of my body, barring any physical difficulties, what within reason I'm able to do. Also, I have the ability to determine where my thoughts go. I can have the intrusive thought like, what if I want to molest children? That what if can come up. Once I start trying to answer that question, I am now doing compulsions. And that's the part we want to help our patients become more aware of and start to resist. You don't decide the thoughts that pop in your mind. You do decide your reactions to them, behaviorally or mentally. We often are chasing thoughts. It's no longer a passive process where this thought came up. It's me trying to figure something out. OCD gives us questions that are unanswerable, and we're trying to help our patients resist trying to figure it out. Let's help you resist trying to get the answers. But why would you do that unless you understand what OCD is? So again, psychoeducation is very important along with the person's experience. Did anybody have a question? I didn't know if I missed something. Okay. Another slide about some of the compulsions are listed here. Some of the overt behavioral behaviors we might do, behavioral behaviors, but some things that we can actually observe in ourselves and our patients, and then some of the cognitive things that we might do. The mental reviewing is big, and people struggle with how do I stop doing that in my head? Awareness is the first step. And then we can use all sorts of different strategies to try to help a person ground themselves or helpfully distract, but not to keep going in their minds to try to get relief that is actually never going to come over the long term. I included this model. It might be a little bit detailed, but scrupulosity, that is worth knowing about, because in our area, a lot of people have very strong faith, and the importance of religion is, a big thing here. So OCD can attack people in their faith area. And this is where, I'm somebody who I've considered to be very spiritual, very connected to church or connected to my religious place of worship. And that's been a big part of my life. Now I'm having doubts about whether I even care about people or whether I even believe I can go to heaven, or maybe I'm going to go to hell. And so again, intrusive thoughts get interpreted as significant or meaningful. So I'm afraid of sin. I'm afraid of God. I become preoccupied. Because of that, I start doing everything to either try to get clarity or relief. And then my faith gets more and more contaminated, and I'm losing who I believe I am more and more. I can think about people who they would now dread thinking about the Holy Spirit or dread the thought of going to church because it's become so affected by all these other intrusive thoughts. And what happened is when they first had the thoughts, do I really love Jesus? Or what if Jesus were to have sex with, I'll fill in the blank later. But once they had those thoughts, they decided this means I'm a horrible person. They decided this means God is never going to forgive me. I don't even know who I am. What have I been doing my entire life? Well, it was a blip. It was an intrusive thought that didn't have to mean anything, but it got misinterpreted. And the thing to know, again, is that OCD is an insidious bully that has this genius way of attacking where it's really going to get you. It's going to go at your values. So when I think about school teachers who have told me about their fears of harming children or molesting children, what that tells me is how committed they are to their patients or their students' well-being, to their students' education, to their students' effective growth as people. They love their students. So OCD hits them in an area where it feels intolerable to have these unwanted thoughts. OCD gives you what it thinks you can't handle. And so then we try to show ourselves, help our patients learn, OCD, I can handle what you give me, and I can handle even more. So basically, it looks like this, and I know there's been a lot of repetition. I hope you feel at this point like you could explain this if you needed to anybody you needed to explain it to, the intrusive thoughts or the obsessions. When that happens, I have some distress. It could be anxiety, it could be fear, it could be shame, it could be disgust. I don't like distress. I'm going to do something to try to make it stop. Neutralize the distress, undo the thought. I get the temporary relief, but this is at the cost of long-term suffering. And if we look at this diagram, if you think about the compulsions, that's like putting gasoline on this whole fire. If I do compulsions, I'm basically telling my brain, oh, that unwanted thought must have been important. You better keep giving me more of those thoughts, brain. So we want to help our patients in treatment at that first step with obsessions, learn to tolerate having these thoughts, not try to make them go away. But then at the level of compulsions, where we do decide our behavior, we want to stop the compulsions. And so we have a treatment that's called exposure with response prevention. And we'll talk more about that. So psychological treatment, the gold standard is ERP, or exposure with response prevention. You've heard me in this talk refer to OCD sort of as its own entity. We do that in treatment. I don't know of anybody right now who's treating OCD that doesn't talk about OCD separate from the patient. And early on, we'll map out what is Debbie's territory in life and what is OCD's territory. And we'll see that the more compulsions have been done, the patient's territory is getting smaller and smaller, and OCD's territory is growing. But I find that illustrating these concepts is really important. I want patients to have worksheets to take home, explanations, especially in the early part of treatment where psychoeducation is so important. With anxiety disorder treatment, the crux of it is often doing the opposite of what you think you should do. Why are you going to do that unless you understand the strategy? So OCD, we talk about as separate. And is that you or is that your OCD? And are you playing for Kim's team or are you playing for OCD's team right now? Assessment will generally involve at least 1 to 2 sessions, sometimes more like 5, to really help people get on board, start to identify the full range of obsessions and compulsions. With ERP, generally we're thinking about 4 to 16 sessions. It can be much longer than that, but that might be what a typical course of treatment is for somebody who comes in and benefits from exposure with response prevention. That might be a course of treatment that they do in 2014. They may come back for boosters or another course of treatment later on. This is a disorder, again, that's going to show up in different parts of life. We don't have to know exactly why it's happening. What we do know is we have strategies that can be very beneficial. And if we can get our patients on board with the strategy, then we are empowering them in ways that I just think are so incredibly meaningful. We are never trying to make the thoughts go away. Okay, we don't stop our brains. Our brains are infinite. You could never guarantee me I won't hiccup again. I can't guarantee you your stomach won't growl. We don't know what our brain is going to give us. The question is, how am I going to respond to what my brain gives me? And in treatment, we're bringing on the uncertainty. We're bringing on the distress, so patients can learn that they can tolerate and live with what they didn't think they could tolerate. So bring it on, not make it stop. Now, I say that like it's some just straightforward thing. This is a disorder like other anxiety disorders that is excruciating for people. And it's no easy task to switch your mind to bring it on. But that is the philosophy that we're trying to help our patients understand and resonate with over time, because they'll have their experiences of how they've tried to stop these thoughts. Our patients are smart. Our patients are clever. If they could have stopped these thoughts, they would have. It's not that you weren't doing what, somebody might do for an external problem and have it work. It's just, it's not going to work with OCD to try to make it stop. And then definitely we'll also add concepts from acceptance and commitment therapy, or ACT, and self-compassion is a big deal in OCD treatment right now. I've referred to OCD as a bully a lot. Well, in the face of a bully, a compassionate person can be really helpful. And we want to help our patients be compassionate to themselves, especially as they're doing the hard work of treatment. Okay. Maybe we'll just pause for a second in case somebody has something they want me to try to answer. I realize I've been talking nonstop. If somebody wants a break from me talking and has a question or a comment.
There are several, Dr. Wilhelm. I was saving them till the end, so it's really how you would like to proceed.
Maybe we'll do 1 or 2, just so it's a little bit of a breakup from me nonstop talking, and then see where we are.
Okay. So first, Nicholas just wanted to point out that you had 218 people in here. So this is a really hot topic. Just wanted you to know how important this was. I think that needs to be pointed out. Several of these are kind of going back to OCD and anxiety. That's coming up several times. Could OCD occur along with generalized anxiety disorder? And along the same lines, could you say a person with anxiety has the obsessive thoughts, but maybe not the compulsions?
Again, great questions. Thank you. I think I would say figuring out, is this generalized anxiety disorder or obsessive compulsive disorder or both, is a conversation that I've heard a lot of people have at conferences with who I consider masters of this treatment. It is not always clear exactly which is which. And I feel this every day. I know with our psychology interns, this is a conversation we have. Generalized anxiety disorder is thought to be where the worries seem more every day. You're worrying more than you want 6 months at a time or over 6 months. There's the concentration problems, the irritability, you can't sleep, you're tense. And for that, it can feel like, okay, these are real life problems, whereas OCD is more bizarre thinking. In conceptualizations, they often look the same. And I don't know if I shouldn't be saying that, because there are many people I know, I have them diagnosed with both, and other providers have diagnosed them with both. I think this is a model where I'm looking at a behavioral assessment. When this worry thought shows up or when this obsession shows up, how are you responding to it? What are you doing with it? And all the efforts people engage in to make these thoughts go away can make them definitely more amplified over time. So the GAD versus OCD distinction can be tough for determining. And somebody like Jonathan Grayson, who is amazing, like hearing him say, well, why does it matter? We're going to treat it this way. We're going to help people develop these skills. I say all that. And at the same time, with GAD, sometimes we can help people look at the probability of their worry. And they may be able to say, okay, that's unlikely to happen. Or if that happens, I'll be able to cope with it. And they're able to dismiss it a little bit more. We're not going to be able to reason with somebody with obsessive compulsive disorder. And all those attempts to reason may backfire more. I should never be somebody who is giving reassurance to my patient. And that'll be a discussion we have. If people are coming in treating therapy as an opportunity to get reassurance, then I am co-compulsing with them, and I need not to do that. So this is where therapy goals and an understanding of the person's own functional analysis is really important. You can't talk somebody out of their obsessive thoughts. With GAD, we may be able to shake up some of the rigidity of the thinking. Still, whatever shows up internally, I want people to have a flexible approach to it. So whether I'm able to say, there's a thought, I'm going to go ahead and drive my daughter to the play I said I was going to drive her to. I'm not going to let myself get hooked by that thought. Or do I have to check to make sure that my husband got home okay? I better call him and I better call him again. We don't want our patients doing that, whether it's OCD or GAD. We want to give them the tools to treat thinking more flexibly, either through diffusion, reappraisal, or just letting the thoughts come. And then we want to help them resist doing all the behaviors that perpetuate the problem. With GAD, I'm also big on worry time, like setting aside a time where people will 15 or 20 minutes a day, just let themselves worry. They get a different relationship with those thoughts. So that was something. And then Carrie, remind me of the other question. There was the GAD versus OCD one.
It was along the same line. It was, would it be fair to say that someone with general anxiety disorder has the obsessive thoughts, but not necessarily the compulsions?
So that's a great question as well. I am one who, I guess I've just been indoctrinated to not really subscribe to this only obsessions or pure O. Sometimes that's been described in self-help manuals, pure O, that the person only has obsessions without compulsive behaviors. I don't believe that's true. I think if I have a painful thought, that I'm probably doing something to try to neutralize it or stop it. If I just have the thoughts and I'm not doing something about them, then how am I having a disorder? So I think lots of times we may not be able to detect some of the mental rituals that are going on. Like I'm, just saying a prayer every time this comes up, but I haven't told my therapist, or I'm secretly saying to myself, this can't really be happening to me. This can't really be happening to me. This can't really be happening to me. And I get myself some relief. I just don't think we're having these intrusive thoughts that we're not doing anything in response to. And it's a disorder. If I just am allowing them and they're not causing me to do anything different, shutting down my life, then I don't think it meets the criteria for disorder. So basically the answer is, I believe people are engaging in some type of neutralizing behavior with their internal intrusive experiences. So this slide has been up for a while. We do talk about how anxiety is part of being alive. This is a treatment that's going to teach you how to tolerate distress and anxiety, show you that you can handle it, because anxiety is safe and tolerable in all contexts. It's unpleasant, but the system that Mother Nature gave us to keep us alive is not going to backfire on us. No, we don't want people stressed continually. We don't want cortisol flooding their body. And if they have effective treatment for OCD, then they are lowering their overall stress. So we tolerate short-term anxiety and distress for a long-term gain. That is treatment. We're working together. I think I've said we don't have to know exactly why OCD developed. We do know how to treat it. And having some metaphors that help people appreciate what's been going on may be really important for engaging them in treatment. So ACT has been looked at in OCD literature. There are studies that show the addition of acceptance and commitment therapy strategies didn't really add more to the positive effects than having the exposure with response prevention. ERP is such a powerful treatment, but using some of the metaphors, using some of the engagement strategies with ACT may be something that gets patients more on board. So when I say that, metaphors might be the Chinese finger traps, where you find that the more you try to pull out of those finger traps, the more you get stuck. So we've got to lean in and be willing to have the anxiety. The bully is a metaphor we use a lot. Passengers on the bus, this is helping people understand you drive your bus. You are the determinant of your goals and your values. And we want you to be able to keep steering and driving your bus. Unfortunately, OCD has given you a lot of rowdy passengers. Is this really OCD? What if your therapist is just telling you that? Do you even care about anybody? Has anything you've ever done really mattered? Do you even love God? Could you molest that child? They're like rowdy passengers on the bus. And we want our patients to realize their job is to keep driving, even with these rowdy passengers. A bus driver can't stop the bus every time a rowdy passenger starts yelling or throws something. If the bus driver stopped every time, the passengers grow in their importance. So make it stop can become like another metaphorical passenger on the bus. We, again, just want to highlight you decide your goals and your values, and we want you continuing to go in those directions. And ERP is a treatment that can help you do that. We use a metaphor like the chessboard, where people feel like they're in this fight with their minds. Am I the black pieces? Am I the ivory pieces? You can't win in that game. Who are you? You're the chessboard. You're the place where all this happens. I'm the place where these thoughts, feelings, urges show up. So I, knowing that, have more of an opportunity to decide what I do with them instead of having them dictate me. And this is, again, important because people will, just last week, a really wonderful gentleman said, well, if I'm not my thoughts, who am I? You're your values. You're what matters to you. You're the person you want to be, and you're an infinite number of other things. Your thoughts are part of you. They don't define you. And when it's OCD, we need to be strategic in how we treat the thoughts of this bully. Partners, family members are really important in treatment. I'm not sure how much time we'll have to get into that, but this is something that is so much better when we can have a supportive partner coach or family members that are on board with what ERP involves and how they can support and nurture their family member doing the hard work. So when we are doing exposure with response prevention, we use our patients' experience with OCD, what they've lost to this disorder, really mapping it out, what I've lost in terms of time, what I've lost in terms of school opportunities, job opportunities, relationships, just how OCD has been so costly. This can be really important in helping motivate people to do the hard work of treatment and keeping them engaged in treatment. And then this is not a calm down treatment. And slowed breathing, progressive muscle relaxation, even mindfulness, these things would not be effective treatments for OCD. They are wonderful lifestyle strategies. They help manage stress over time, and it's nice when you incorporate those things in your daily life. As far as what is effective treatment for obsessive compulsive disorder, we want people facing what they have been so afraid to face, to learn they can tolerate uncertainty, to learn they can tolerate distress, to learn that it's unlikely the catastrophic thing they thought was going to happen actually happens. Because avoidance, compulsions, rituals, they prevent me from learning that I can handle life. And then OCD grows bigger and bigger and takes up more of the values that matter to me. So I say all that because in treatment, people are going to be anxious. We want your amygdala firing. Your amygdala does not learn through reason or logic. Sometimes we'll talk about a tea example. If I put a tea bag in a mug of cold or lukewarm water, at some point it might become tea, but to make tea, I heat up the tea bag. I get the water hot. We want your amygdala firing so that you learn something new, because you've been operating as though if your amygdala is firing, you've got to make whatever's going on stop, whether it's stop the thoughts or stop doing the life-affirming activity. No, your amygdala gets going in treatment. We want that. That's good. With exposure, we're talking about 3 types in general. The in vivo is I'm doing a situational real life thing, like driving on the road and not going back to see whether I just ran over someone, or I am looking at pictures of children, or deliberately spending more time at a park near a school. I'm going towards what I've been afraid to go towards. I go to church if I've been afraid I've been offending God, or I am in the kitchen cooking if I'm afraid that I could stab my husband. So we do situational exposures. We also do imaginal exposures, because there are so many things that we can't confront in real life, whether I'm going to go to hell, whether I'm going to develop a catastrophic illness. The imaginal exposure is where I create a script of this really catastrophic imagined scenario happening. And I read that script and I play that script. It's on the phone. We play it over and over and over so that the patient gets a different relationship with their brain's ability to construe this terrible outcome. The exposure is done without compulsions. It's done without rituals. So if I think about how I actually did hit a kid, this is imagined, I did hit the kid, because I'm not exposing myself to it's all going to be fine. I'm exposing myself to this scenario that I don't think I can handle in my mind. So we do that over and over so that people learn I can handle what my mind gives me without having to shut down my life. Now, whether we're creating a script of an apartment fire where the person's pet died, or they did contract a horrible illness and gave it to their family members, when we're creating those scripts, we are not saying we're okay with those awful things happening. We are not saying that's all right to just say, oh, well, that's life. That's not the case at all. We are saying that your brain has this habit of giving you what you don't think you can handle. We want to show you you can handle these thoughts. The imaginal exposure is about tolerating the idea of these things happening, not that we're ever okay with those types of things happening. And when we do treatment, we free people up so that they can live more by their values than the rules that have been shutting them down. Why would somebody read a script where they actually were arrested for molesting a child when they've been this school teacher who's won all these awards? Why would they read that script every day for a few weeks? Because their life was being hijacked by fear of that. So now it's words, it's thoughts, it bugs me, but it's not shutting my life down so that I can be more of the teacher I want to be. I can be more of the husband or the son I want to be. Interoceptive exposure is where we often bring on the unwanted body sensations. So that's part of the treatment for OCD as well. Sometimes they don't want to feel their heart racing. So we will run in place, or we'll do stairs, or we'll spin in the office. We will bring on those sensations. And if you let yourself have those sensations without catastrophizing them and trying to make them go away, you learn they come and go. Okay, I see that it's about 5 afternoon. I'm going to say a little bit about emotion processing theory versus inhibitory learning theory, but I'm going to go on a little bit on that. So we want exposure. The thoughts that I didn't think I could handle, that I've been trying to make it go away, that I've been trying to neutralize, we do the opposite with effective treatment. Let me face the thoughts. Let me face the thoughts in actual life. Let me say them out loud. Let me write them down. Let me have all sorts of exposure. We put the dreaded thoughts on people's bedroom walls. Sometimes sessions will involve us putting signs of those thoughts everywhere. I keep coming up with the scrupulosity ones, but I hate this religious figure. I'm going to hell. I don't want anything good for anyone. All the dreaded thoughts, we bring them on. So a person learns they're just words. They don't have to define me. That's big. And then being in the situations. But when we're doing that, we could think that we're going for what we would call habituation, where a person learns through time, okay, I can handle this. My fear goes down. What is probably more important than habituation, like warming up in a swimming pool, more important is probably what we would call tolerance, learning I can handle this unpleasantness, whether the anxiety, the distress goes down or not. And so that's what this slide is about. For years, it was thought that we needed habituation for treatment to be effective, which means I keep going into the situation and over time, my anxiety keeps going down within sessions and across sessions. So that's like that curve keeps coming down more and more. That is not actually associated with long-term learning. The fear reduction is not predictive of the outcomes we want as much as what we're learning. So whether my fear goes down or not, if I learn I can handle this, if I learn the disastrous outcome that I expected didn't happen, that tends to be more durable. So in our debriefing of exposure sessions, we're always talking about what did you learn? And I say debriefing because we are consolidating and learning. This is not just a bunch of tricks. This is setting up exposures to test out people's ideas of what's going to happen, to help them see the catastrophe did not occur and that you were able to handle what you didn't think you could handle. Now, with the emotional processing theory versus inhibitory learning theory, inhibitory learning is the model right now where it's more focused on what you learned, not whether anxiety went down. What did you learn? And learning often happens best through switching up the context, through giving people all sorts of powerful cues, through doing the exposures in different environments. So in anxiety disorder treatment, traditionally we've developed hierarchies, helped people face difficulty like a ladder. I do the first step, so I learn I can do the second step, and I keep going up that way. But maybe life doesn't work that way, and maybe it shouldn't just be a clear hierarchy that's linear. Maybe on note cards, what we do is write down the situations that you have been avoiding. And then we talk about why it's important for you to let yourself go in those situations. And we put them in an envelope, and then we draw them out randomly. This is the exposure we're going to do in today's session, and then build on that for homework across the week. And the patient may take an envelope of the exposures that they're going to do and pull one out randomly each day. Learning happens when we violate what we thought was going to happen. I thought this terrible thing was going to happen, and what actually happened was this. Now, that's not saying it's always great, but there's an opportunity for learning instead of continuing to do compulsions, rituals, and avoidance that keep me from learning. We want to help learning be impactful and generalizable, because old fear memories tend to be really durable. So we're trying to create new learning. This is an example of how we might do a hierarchy. If we do a hierarchy, as I've been saying, I'm more likely to put these items in an envelope and we pull them out randomly. And then we also try to intensify some of the exposure features. So using public restrooms, walking the dog, touching the leash that I didn't think I could touch, going into the storage room and not just sitting there for a minute, but rubbing my hands on some of the storage items, making it more impactful. The learning is what matters. Now, response prevention, that is where we're trying to get our patients to agree not to do the ritual. So you're not going to do an exposure here where we're sitting on the bathroom floor and then go downstairs and wash your hands in the restroom downstairs. Or you're not going to practice here where we're, writing 666 on our arms and then go home and, wipe it out and pray to God to forgive you for that, because then you would be doing rituals. and that is erasing the learning that happened. The 666 stays on your arm, or carrying an unwanted thought when you go to church, that stays in your pocket. We are not engaging in the rituals. And what we want people to see is the anxiety, the distress comes and goes. That the rituals are what has kept it going for so long. I often have this fantasy of, what if people who struggle with OCD early on, especially adults, were able to get some clear information about what was going on. When you first had that thought that you actually hate the Holy Spirit, when you first had that thought in the middle of the night and it felt like your entire world turned upside down, what if you could have known at that time that that was middle of the night thinking, and that everybody has thoughts like that, and that's OCD trying to trick you? Your learning history would be different. You maybe wouldn't have developed all those compulsions and rituals. So we will agree on what are the rituals you're going to avoid doing. We have to map this out. And it's my job as a therapist to have conversations where we get at the rituals and the compulsions and the avoidance behaviors that are going on, especially the mental ones. Even it can be self-reassurance. Okay, I'm just here doing treatment. God really understands me. I'm just doing treatment. God really understands me. So I'm taking away this idea that I can tolerate the distress. And again, we're wanting people to learn they can handle the uncertainty they didn't think they could handle, and they can handle the distress they didn't think they could handle. Why? Because they want their lives back, because they don't want to keep being dominated by this life-eroding bully. So this is a slide that's maybe just a summary of things we might do. With contamination fears, we're going to touch the contaminants. We're going to, do things we wouldn't typically do in everyday life. Sometimes people have had some of the department staff touch their hair, or certainly touching all sorts of surfaces in the hospital. This has been very different during COVID, so I'm not going to get into that. We followed CDC guidelines on that. But once people are in their homes, we're touching stuff, we're not avoiding stuff, and we're not overwashing, and we're not asking for reassurance. If I'm worried that leaving the stove on is going to cause a fire, or if the hair appliance is still plugged in, the house is going to burn down and kill my dog, we still leave things plugged in. We're not going around and unplugging everything. And sometimes even experiments where we have the washer and dryer running while somebody leaves their house, or they want to go back and check that they closed their garage because there's this doubt, did I close my garage? We want to keep them from doing that. That's checking that's going to reinforce this whole cycle over time. I'm going to think the upsetting thoughts on purpose with OCD. It's not make the thought stop, it's show myself I can have this thought. So I mentioned putting signs across this office. They take them home, they put them in their room. We want to have them available. People will write the thoughts on their arms. So make it available. Show I can still live my life even when this obsessive thought is here with me, and not, again, trying to undo, not trying to neutralize. And then the opportunity to help things be not just right, that's infinite. So we can mess up things when they're here in session, just throwing things on the floor. We can ask them to wear clothes inside out. We can ask them not to wear the makeup they typically wear. There are all sorts of things we can do to help people face what they didn't think they could face. I included this because the reassurance seeking is a big deal. And we really want to get information about this from our patients and their family members if we can have them here. OCD treatment really benefits from having supportive family members and partners. And if you think about it, family members love their individual who is suffering. They want to alleviate the suffering. So if you ask me, are my hands clean enough? And I don't want you to suffer. Then, yeah, your hands are clean, honey, you're fine. Or if you ask me, is that a bad thought? Does that mean I'm going to go to hell? Then I might have the tendency to say, no, it's a fine thought. Everybody thinks things like that. You're fine. That kind of reassurance that I provide as a family member is called accommodation. And it is also going to perpetuate problems with OCD, because what the person learns is, go ask for more reassurance. Go ask somebody else so you can feel okay. So that it disempowers the patient, but it's another compulsion that's going to drive more obsessive compulsive disorder severity. So we want families on board to realize, because I love you, I can't answer that question. Or I think this might be OCD tricking us, so I'm not going to answer. We're going to give patients exposure to the uncertainty, not tell them what they want to hear, because then the family member is playing for OCD's team. You might realize this needs to be clarified and explained. And we can't get everybody in as far as family members or help with treating the patient. But when we can, it's a really essential idea. And, over Zoom, this has happened more. If it's in office, I'll ask, can we call your partner? Can we call your sister? Because I don't want family members to keep doing the reassurance. The reassurance seeking is one of the most entrenched and problematic compulsions. So a reassurance coupon could be, you get one question a day. And this is negotiated. The patient is involved in how we figure this out. So having those kind of relational skills is really important. Relational skills built on psychoeducation and evidence-based treatment. We'll make a form. This is sort of the general idea, but we're going to talk about what is the specific exposure you're going to do. You're going to go to church for this long, or you're going to drive on this interstate, or you're going to go to school and be part of some of the educational activities. And then what are the compulsions or safety behaviors that you're going to resist doing? We identify them. You're not going to go in and wash, or you're not going to drive back and check. And what are you afraid will happen? So we want to identify, what do you think is going to occur? And we want to see how strongly you believe that, get levels of distress. And then we want to see what actually happened. And this is, again, a learning-based model. So the conversation after the exposure with response prevention is, what did you learn? And then beyond that, as we strengthen that and deepen that, how are you going to keep this learning going over the coming days? It's not one and done. We need the exposures to continue. I think that's all I'm going to say on that. We're at 12:16. Okay. And so what patients might learn, instead of it's too dangerous to touch this, I'm uncomfortable touching this, I can do it anyway. Or instead of checking this 24 times as essential, I'll check once and walk away. Instead of this thought means I'm evil, maybe not. I don't get to know for sure. I can handle that. So people will ask, what do I do if I'm not going to do compulsions or rituals? Well, the awareness first to get your resolve and your intentionality to resist rituals is huge. But affective labeling, I can say I'm nervous and uncomfortable. And I can own that without having to make it stop. Also, exposing to the uncertainty. Just maybe this did happen, maybe this didn't happen. I don't get to know for sure, and I can stand that. That's the messaging we want. Not I have to know, but maybe yes, maybe no. I don't get to know for sure, and I can live with that. Jonathan Grayson is big, as many people are, on just identifying from the beginning of treatment. If treatment is successful, we improve your ability to tolerate uncertainty. And then he goes on to say, the only people who are certain are stupid people, and you are not a stupid person. The demand for certainty is the issue. We don't get it in this life. And if we want to live fully, we probably are better off embracing the uncertainty and appreciating our willingness to take risks when it comes to value domains. So key treatment lessons: anxiety is safe, tolerable, transient. It does not require the performance of rituals to diminish. And that's also the case with shame and disgust. I don't have to do rituals to tolerate and allow this painful feeling to pass. The feared outcome, the focus of the obsession, is unlikely to occur. We never say it's not going to happen. What we're going on is the idea that if you keep doing OCD's rules, your life is getting smaller and smaller. We have the experience of that for you. Is that what you want going forward? Nobody's going to do anything unless it's worth it to them. So we're using our patient's own experience, again, to see the costs of OCD so that they are bolstered to do the hard work of ERP. Tolerating uncertainty becomes more manageable. I don't get to know for sure, and I can stand that. And then I think I have a couple more slides. So if we can help, again, people who are family members, friends, not accommodate, not give the reassurance, not provide the audience for confessing, not clean everything every time they come into the house, or, set everything up so the patient is never in distress. These conversations can get pretty hot, as you might imagine. We come back over and over to the patient's goals and values, and we want them on their team. I probably am not going to talk about when it's really rough with family members and the patient's not really buying into treatment. Alec Pollard has a whole treatment on readiness and family interventions, but it's nice when people can be on board and working together against the OCD instead of working against each other. We're not going to try to talk people out of OCD. Your amygdala is not going to be reasoned with. OCD wants you trying to reason with it because it's going to grow stronger. It's always going to have a stronger argument because it's going to say, but what if this? What if that? It's going to keep giving you questions, unanswerable questions. Your job is to resist trying to answer them. And then, as much as possible, really honing in on, let's face the discomfort now, short-term pain for long-term gain. Okay, this is the final slide. We're hopefully clear that struggling against anxiety, struggling against my mind is not going to work. I have to take a different strategy. Let the thoughts come, let them be here. Learn that I can live with these thoughts. When I thought I couldn't do this talk if these conditions weren't set up, show myself I can do what I didn't think I could do, and disaster is unlikely to occur. Uncertainty, sort of the crux of the issue, is neutral. It could be better, it could be worse, it could be what I expect. We don't get to know now. We'll see the future when we get there, but we do have to live now. And then we're trying to diffuse from these thoughts, not be overly hooked by them, not be resisting them, because what we care about more is the living instead of the tug of war with our brains. I would say, and maybe this is probably the best way to end my talk, if you have interest in this area, if you want to know more, the International Obsessive Compulsive Foundation is phenomenal. IOCDF.org, in my opinion, was always amazing. Throughout the pandemic, I have been repeatedly in awe of the resources that have been provided, and they are still there. So if you would want to look at IOCDF.org, it's got science-based information for adults and children, tons of resources. Peace of Mind Foundation also has amazing resources. And then Anxiety Canada is a good resource. And I did not leave room to put ADAA.org, so the Anxiety and Depression Association of America. That is another fantastic resource. These are internet sites where there is credible science-based information and options for treatment ideas. So much of the quest here is why? And then our patients are on the internet looking for answers. That is part of a checking compulsion. We don't want them chasing for certainty on the internet. We need to have reliable resources to point them to and to help back us up when we're doing this treatment. Okay, I think that is the end of everything I had to say. Thank you guys for listening.
I have about 8-ish questions, and I know this ends at 12:30, so if anybody needs to go, including you, Dr. Wilhelm, then we can stop, or we can go as long as you're willing.
Well, thank you, Carrie. I think I feel really strongly about ending on time for people, so we'll go till 12:30, just so people get to do what they want to do.
Perfect.
Thank you.
There was a question about getting a copy of these slides, so I want to let everybody know on the main conference landing page is a link for you to be able to get the slides. It'll pull up our brochure, and this session is highlighted in blue, so you can click on that and it will take you to these slides. Early on, there were some questions under subtypes. Some people wanted to know if being obsessed with being single was part of the relationship subtype, if there's a health anxiety subtype, gender and gender identity subtype.
I think those can fall into the categories of relationship OCD or sexual orientation OCD. And there was the health anxiety. Sometimes that can be tricky. A lot of health anxiety really emerged more over the past couple of years. And sometimes people have a separate illness, anxiety disorder diagnosis, for me, it often does sort of fall under the umbrella of OCD. So this is where you want to be really careful about what they're saying they're afraid of. But in general, if somebody has been worried about getting sick and, having this cancer diagnosis and, these other catastrophic things that might happen to their health, it often overlaps with worries and doubts about other areas. So I don't know that it's a formal subtype. There really aren't formal subtypes. It's just sort of how we talk about these different areas that show up a lot, but it can absolutely be part of OCD.
Leading kind of right into that is a question about why we use general OCD. I'm wondering if there might be some empowerment in looking at the subcategories, for example, scrupulosity, if I'm saying that right. Is there empowerment in kind of dividing that out and having something specific versus the umbrella term?
Again, a great question. I think whatever is going to speak to your patients and speak to you as a provider offering treatment. Yeah, we have those names, whether it's pedophilic OCD or sexual orientation OCD or scrupulosity, because it does normalize and it does, make something that seems so shameful and isolating more, okay, other people have this too. That is so hopeful. I mean, light comes on. And at the same time, I think I probably also want patients to realize that really over time, the content may be irrelevant. The content is specific to you. OCD is going to get you where it can get you when it can get you. But if you talk with people who've had OCD over their lifetime, the different manifestations change. So at one point, I'm worried about, contamination. At another point, I'm worried about my mom dying. At another point, I'm worrying about everybody hating me at work. At another point, I'm worried I'm going to contract this terrible illness. So when you look at people's experiences, the different types of OCD show up in different ways for people. Reed Wilson wants people to understand and says pretty directly, content is irrelevant. Dave Carbonell says content is for suckers. And that can sound harsh, so I hope it's okay I said that. Just let's not let this bully keep defeating us with a new message. Same theme, demand for certainty, demand for perfection, and hyper responsibility. If we can get people to tolerate a general uncertainty, I don't get to know my sexual orientation completely, totally. I don't get to know whether I'm going to go to hell. I don't get to know whether I'm going to be in a car accident later this afternoon. That is the world I have to live in. And to insist that I get certainty is going to make it pretty hard for me to live fully. So the question was great. And, do whatever is going to work for you. Probably I'm very influenced by Reed Wilson with talking about how content is irrelevant. And he'll just kind of say, all the different messages can be like garbage in the garbage can. You're not going to pick out this garbage is more important, this garbage is less important. It's all garbage. It's hooking you where it can hook you. But above that is this intolerance of uncertainty. So let's not give OCD what it wants. Let's not say, I can't stand not knowing. Let's show ourselves, oh, OCD, yes, I can stand not knowing. And because I want my life back, I am willing to not know.
Anything that you can talk about in terms of the differences between OCD and obsessive compulsive personality disorder?
So the obsessive compulsive personality disorder, like Carrie said, is a personality disorder. And there are people in the field who really hate that these sound alike at all. I actually would say they do come together for patients I've seen more than what the literature might suggest. But with the personality disorder, this is where I think people have to behave in a certain way and things must be perfect. I may be frugal with my money. I, have all these rules about how things are supposed to go. So it's really something that affects people's relationships with others. And again, the personality disorder, it's showing up in these different ways across life. The person may not experience it as ego dystonic. They may be fine with their views while other people are struggling. It is separate. And that's the thing to keep in mind. Jonathan Abramowitz will strongly say, I hate that OCPD sounds like OCD. I actually have people where both disorders have been the case, but it's not always like that. They are different disorders and they require different treatment. The one overlapping issue, I think, is the perfectionism, expecting perfectionism from me and expecting perfection from other people, but different disorders, different treatment.
In your final minute, I'm going to skip down to something that you can actually maybe answer. In 60 seconds, do you have any good book recommendations about OCD or a favorite E/RP book or workbook?
There are great ones. If you look up Jonathan Abramowitz, Getting Over OCD is a very good book. Okay, so Jonathan Abramowitz, it's a self-help manual. It's in its second edition. Jonathan Grayson has his Living with Uncertainty or Freedom from OCD. It is also in its second edition, but the book either by Jonathan Abramowitz, Abramowitz, or Jonathan Grayson, Grayson. Also, if you wanted to look up anything about Jonathan Grayson on YouTube, there are brief clips he's made which explain OCD so well. These are masters of treatment. Reed Wilson has wonderful resources. Reed Wilson, great stuff with getting some ideas. And I'm trying to think. There are several other that if you want me to put them in an email or something, I can. But that's where I start. Grayson, Abramowitz.
Okay. And Nicholas has been great. They've got some links already posted up here for what you just said. So that takes us to 12:30. I will kind of download the chat and give that to Molly so that she can send that to you. But thank you so much. There are lots of thank yous. Lots of this is great information. I'm going to go back and look at this some more. So just know that we always appreciate when you come and present at our conference.
Thank you for having me. Thank you for staying and listening to me babble. And thank you, Carrie, for moderating so kindly. I appreciate it a lot.
All right. Happy lunch break, everybody. We'll see you for the next sessions at 1:30.
Enjoy your conference. Thanks, guys.